Good morning, in case you're just joining us. And if you have been with us since we began the show at 6 a.m. in the morning till now, we appreciate your time. We told you that among the conversations that we will be having in studio this morning, we want to delve into the health sector. Remember, health is one of the things that the Kenya Kwanza administration pledged that it is going to revolutionize once it assumes power. Of course, this recently, they marked 1 year in office. A lot has been said with regards to how much has been achieved, but we just move this conversation forward. And recently, there was that new development of the health bills that are supposed to sort of form, the foundation upon which the universal health care is going to be, vexed upon. And this is actually not the first time that the country is attempting to launch this universal health care. We've been on this road before. So what did we miss, and how do we ensure that we get it right this time around? Among the key bills that are currently being discussed include the Primary Health Care Bill of 2023, the Social Health Insurance Bill, we have the Facility Improvement Bill, we also have the Digital Health Bill. Of course, there's the nitty-gritties as to some of the proposals contained in this bill, but this morning we just want to sort of have a conversation to look around the Primary Health Bill that also talks about the preventive approach to healthcare, as opposed to focusing more on the curative approach to healthcare. There's been a concern about how much we invest and focus so much on curative healthcare as opposed to the preventive. So we want to talk about this, among other issues that shape the health sector in general. And I have with me in studio, it's actually a panel of Secretary Generals this morning from the Kenya Union of Clinical Officers and the Kenya Medical Practitioners and Dentists Union. So I'll begin. Dr. Davji Atela, the SecGen KMPDU. Thank you for creating time for us.
Thank you, Safin.
And we also have with us George Gibore, the SecGen, the Kenya Union of Clinical Officers.
Good morning, and thank you, Safin, for
Karibuni sana. All right, so we just pick this conversation up. I know this is actually one of the things we cannot say that we have discussed enough. Healthcare is a very critical issue in our society today, especially looking at our context as a country. In as far as we have that dream and vision to ensure that every Kenya in the remotest part of this country gets access to healthcare, not just healthcare, quality healthcare, and not just quality, but in healthcare that they can be able to afford. This is actually something that will need a lot to be done, and that's why we're having this conversation this morning. But let's begin from the big elephant in the room, the preventive healthcare. And the genesis of this, Davji, if I may just start with you, there was that concern that we had shifted our mind to really focus on the curative approach of delivering our healthcare to our population. Probably just tell us the genesis of this conversation about preventive healthcare and why is it important? Why should we be concerned at this juncture?
Safin, thank you for inviting us to this station to discuss this issue. If you look clearly, the issue of primary health care or primary care, as some will call it, it's not a new concept. It was a concept that was coined and made as an Alma Ata Declaration in 1978 in USSR. And what was the protocol? What was the concept behind it? It was just trying to make healthcare not to be an issue of just the doctors and the hospital only, but to be an issue that also encompasses the community and have to look into the social indicators within the community. So that's where the issue of primary healthcare comes into being. I know from that point of Alma Ata Declaration about now over 40 years, there is a clear plan on how this thing was to be instituted by different countries and the challenges that have been seen by different countries, because some countries have been looking at it the way we are now looking at it, where we're looking at primary health care as primary care. Where primary care, you look at the individual disease from a patient, and also you look at the pattern of that particular disease. But then with primary health care, you look at the holistic approach of a disease within the community. You look at, for example, if people have diabetes, people have hypertension within the community, what makes the person who has diabetes not to take drugs? What makes the person who have this particular condition not to go to the hospitals? And if they go to the hospital, what will make them not to continue visiting the same facilities? So it becomes an holistic approach. And how do you prevent such a kind occurrences, the disease outbreaks, how do you monitor that? So it divides the aspect of having only the healthcare personnel to this, to have the community, the people becoming understanding their role in the delivery of services. That is the concept of it. But when you look, ideally, the curative aspect and the preventive aspect, they go hand in hand, because even if you go to the community, there, first of all, as you do even the survey, as you check, there has to be people who are already sick. So these people should actually be treated. If you go and, for example, you have these machines that are being given out, and and you check somebody and they have the high blood pressure, what will be the interventions of these particular community promoters? What will be the interventions of the community to understand that they have this particular condition? That is the approach that has to come into place. I know there has been a narrative that the country has focused more on curative care than on and neglected the preventive care, but I find that the curative aspect of it is more neglected. That's why we have been saying clearly that the hospitals across the country are dysfunctional, because it's not a singular approach to care. It's an holistic approach. We must have the health professionals, we must have the commodities, we must have the mopping aspect that makes the community understand this concept. It should not just be a one line. Yes. All
right. I don't know what you think, George. He's saying that it's not a new concept. Probably yes. We've been down this road before as a country. Do you think what created the missing link, and why did we seem like we shifted from that? Because it's not new, but suddenly it's sort of like it's neglected, though it's important.
Yeah, I think I totally agree with him. It's not a new concept, but you see, the discussion around the Almaty Declaration was also encompassing the socio-economic of those specific countries, for those who are already maybe rich countries, for those who are struggling to make ends meet. And it focused at individual level, it focused at the household, it focused at the community. And now the discussion which is there, if you look at the definition that we have adopted about primary health care, in our own bill is actually the definition that was given in 1978.
That's true.
And that one now gives us the foundation of the discussion on how do we engage about health. So, and then the diversification there is about, when he talks about holistic, it's not about waiting for patient to be sick. It is about for us promoting health. It is about us preventing disease and controlling disease. It's about us now focusing on those who are sick, because we cannot really prevent everyone from getting sick, or rather controlling everything. Then for those who get sick, you can also get curative services. So indeed, when we talk about primary health care, is a concept that takes everything, but it focuses on individual, it focuses on household, it focuses on community. The issue about where we are talking about currently, and if you look at that Almaty Declaration, one of the things they focus about achievement is about political, or rather decision makers buying into the idea, because it is a big issue that they don't normally most of the time understand. Where we are in a country now, we call it more of an achievement, because the political class now are discussing about the primary. Yes. So that is what we normally look at it. As much as we are not into it already, but there is an aspect of political, or rather political leaders and decision makers buying into what we have been seeing, like it is a missing link, where we wanted to focus on the primary health care. And why primary health care? I'm a proponent of the idea that indeed the country need to invest heavily in the primary health care. One, because about over 7% of the admitted cases in our facilities are preventable cases. So we do not say that if we focus there, we will prevent all the 70%. But again, if we do that, then we can prevent even if it is 50% of that in our first year, or 30% of that. And if you do that, you actually save, because they say that every 9 shillings used in what we call preventive care, primary health care, then you save, I mean, every shilling used in primary health care, you save 9 shillings for those who goes for curative. So for us, we are saying, curative focus on an individual. When I'm sick, that's when you focus on me. It doesn't look at the holistic approach. But this comes and say, we are looking at everyone, whether you're sick or not. we want to engage you at that level. And that is why now we are saying, previously we have seen this country launching the UHC more than 4 times. It has not peaked.
Yeah.
Why? That is why we are going there. It indeed, we didn't have the background, or rather the foundation on how to take it over.
So we began at the top.
Yeah, we began there. Then now we are trying to say there is something that we missed. Let's do this. And we really appreciate that the government is doing this, because we have where we can start and how we can be able to assess ourselves going forward. That are we making steps, or are we still static?
All right.
Yeah.
It's good you've told us now. We go back to the grassroots, and we'll look at the status of the grassroots shortly. But just to remind you, the objective as contained in this bill is to promote and fulfill the rights of all persons in Kenya towards the progressive realization of their right to the highest attainable standards of healthcare. That's actually what the bill actually says as one of the objectives that they seek to achieve with this. But Davji, for this to be achieved, and we are all talking about this now, the health, how we deliver health services, we have to cascade it to the local level, begin at the grassroots. I want to get your assessment of how we look like. For example, that person who is in a rural area somewhere, and we are talking about primary health care. This would mean engaging the communities. This would mean the clinics and the dispensaries would be very important in this particular juncture. If you look at the status as is, even this person, after they've been empowered that you're sick, you need to go for medication, even after you tell this person that, this one now you need to go for a doctor to check, when they go to that dispensary and that clinic, what is the status?
Thank you, Safin. But I want to just highlight something that my brother said, and I've heard it being said a lot, that an investment of a shilling in primary health care is a prevention of 9 shilling in curative. If you look at the WHO Health Workforce Investment Charter of 2023, it says an investment of $1 in health workforce is an injection of $9 in economy. And so the problem that we are having is to fragment this issue of health workforce, like now primary on the side, and then forget this other aspect that already is dysfunctional. And to give you a clear picture of the primary health care, or the cost, or the way it is in the facility in the counties, is look at this mother who is in the village. Let's say either in Kagan or in Subukia or whatever part of the country. Then we have, for example, the community health promoters that are coming and telling you that, okay, fine, you have this disease, you have diabetes. Then after that, then you are wondering, okay, where else do I go? Then you'll be told that you need to go to the facility. Facility is about 30 kilometers far away. You go to that facility, there are no healthcare professionals, there are no nurses, there are no doctors, there are no clinical officers. There's nobody there to actually serve you. So from that point, you actually tend to go back and look for how do you then go get this treatment? Because that's the status in the counties right now. So, and then you realize, even in that bill, they have put up this issue of hub and spoke, whereby the hub is the level 4 facilities across the country. And I will say confidently that all our level 4 facilities in this country are dysfunctional. Why? Because there's no any attempt to have investments in them to be functional. And by investment, I don't just mean the health workforce. The health workforce part of it, I will say the counties have done about 20%. When you talk about the commodities in those hospitals, there's a higher probability of you going to those hospitals and not getting any drug, meaning there are no drugs in those facilities. And I think if the acting CEO of KEMSA Labinia will have asked him that he has been put in the river with crocodiles and asked to get out of that river, probably that's why he's not here. Then when you get,
you go that direction, but it's okay.
When you get to those particular hospitals, again, there are no reagents. So in a way, these level 4s that are called to be hubs are not working. We have the spokes, the level 3s and level 2s. We need to have the clinical officers, we need to have the nurses, we need to have doctors, the family physicians in these facilities. They're not there. And this is why we have many cases, of, for example, of cancer, reaching Moi Teaching and Referral Hospital of Kenyatta National Hospital being checked by an oncologist at stage 4. Why? Because in all these areas, there is a blindfolded aspect on it. We do not look at it that, fine, we need to have proper personnel to actually check into this health workforce. So we cannot in any way say that we are going to focus on preventive and forget about curative. These things go hand in hand. And that's why if you look at the Alma Ata Declaration, it was bringing out clearly that we should not forget about, we should not confuse primary care and primary health care. Because the primary care is focusing on just a particular disease, as I said earlier, without really focusing on the whole aspect of it. Because yes, you're going to have 100,000 community health promoters. They're going to be trained maybe in a particular way to have this approach to the health work to the community. But where will these people go? That's why we have to deliberately look at how do we actually improve health service delivery across the country, rather than just focusing on one thing. Yeah.
So what are some of the elements, yeah?
Let me weigh into that.
That would make a successful or a working primary health care system. What should be the key elements that we should be looking at?
Let me weigh into that. Where I started is that I have mentioned that this country and the previous regime, they launched more than around 4 times what we call universal health coverage. Universal health coverage is a concept that came after the Alma Ata Declaration. And the approach people have been trying to crack is that how do we have care that is accessible, acceptable, and available to everyone, universally. And to that aspect, they also think about quality to ensure that everyone access that quality services. What you asked is key. That now we are trying to talk about this, but what is the real situation? The real situation is that we now have a bill that is proposing to employ what we call community health promoters. And the country I've seen as profiling this issue about employing 100. One thing that we are speaking...
Is it 10,000?
Yeah, 100,000. 100,000. And that's what the national government talk about. But already counties, if you look at their position, they are focusing on 108,000. So then that's to mean there is an extra 8,000, which the national government has not focused to provide that they call the community kit. That's the primary health kit that they will be using to move around. One thing I say that this is a positive step toward the right direction in terms of realizing, or rather breaching the gap between the facility services that we do have and the community services that we want now to establish. And the community, what I'm looking at is that this bill is also going to give us what we call an integrated approach. Because these 100 promoters used to be there. We used to call them CHV, Community Health Frontiers, which we said if you want someone to work, you must promote them. So, and hence, if you want them to promote what you're doing, then give them something, an impetus at least to do that, which we look at it that's positive. Now, the misconception which is there, and which we believe that it is the narrative that is being driven by the Ministry of Health, especially the CS, is trying to think that these community health promoters are going to represent the health professionals. That one, it can never happen. Because these are people, if you look at their criteria, or rather qualification, to be enrolled as community promoters, it does not meet the criteria of a health professional.
Is that really what the ministry is driving?
I have seen that if you look at that concept,
I think there is...
Maybe if I can put it in context so that you understand. Why I'm saying that, if you look at the Kenya Kwanza Manifesto, it envisages employment of health professional, 20,000 and the first stage. This was to build the gap, because already the gaps that we talk about in terms of the staff establishment are the health professional, not community promoters. Now, the community promoters are good because they want to bridge the gap between us and the family and the individuals or the communities or the household. Now, if they are going to be there, if you don't have, as my brother has highlighted, the facility do not have the requisite trained health professional who can now be able to see the patient that these community promoters are referring. Then that is the gap that we feel that they are missing, that link, that understanding that you ought also to employ the healthcare workers to ensure that those lower level facility that you have said they will be offering what we call primary care services, then they are available. so that you do not again jumpstart. One thing, and of course, why he had to start at the alma mater. The alma mater is what established what we are doing. It focuses on referral services. Referral services can never function, can never be established if you don't have a primary facility working. So what we are saying is that the primary facility currently as it is not working. Why? There is no facility, there is no healthcare workers, there is no, the lab facilities are not working because there is no reagent, there is no, that's a pharmacy, there's no drugs at that level. So why? People now bypass these facilities, they go to what we call now the level 4, which we want to establish as a hub, which still misses a lot, have a lot of gaps in terms of the staffs that we need to make it a hub. A hub means that you can essentially get almost every services you need at that point. But if today you compare, it is less than around 30% of our facility which at level 4, which can be said to be next to what we can call a hub. Because all those facilities are supposed to be what we call...
This is a countrywide...
Yes, this is a countrywide.
Crisis, yes.
So that is why we are feeling that whenever we are talking about primary healthcare, we are missing a point, especially the leader of a stature of the CS, who is supposed to have the whole approach in terms of how to look at the health system.
So Davji, how do you distinguish between how far a community health promoter goes and the healthcare worker takes from there? Because it is outlined, and among the responsibilities is part of what they're supposed to be doing is to provide first aid and treatment for minor illnesses and injuries. I'm wondering, how do we know what minor is? How minor is minor? And
you know, if you look at...
they then be trained and be given basics on some medical training for some basic things that they're supposed to be doing?
If you look at that particular bill on the selection of, or appointments of the community health promoters, it says that it is within the community barazas that somebody is being appointed, and then after being selected, once it's selected, then it's being appointed by the county authority, the specific counties, and then into operations. There is a gap that exists because the qualifications is just ability to read and write and ability to know one particular language that is spoken by the locals, and being able to be there for at least 5 years, being resided in the same locality. So there's actually need to have a proper training of the community health promoters for them to be actually effective. And I say this is not a new concept because Zambia and Malawi, who have, I will say, have actually invested strongly in the community health workers in this prospect. And you realize in their part, it is just like a linkage. And they have well-trained, but there's a course that has been outlined for the community health promoters to actually know the purview of their roles within the community. So that's actually what is lacking here. We are actually starting by identifying the community promoters without having to look at it, what particular curriculum or training they will need for this work they're going to do. Yes, I know it is very important that that the gap between the community and the service delivery has to be there.
Yeah.
Yes, it's a very important aspect. The other thing is very clear is that actually that bill provides the penalties where if a community health promoter goes beyond the mandate that have been given, the punishment that they can have. But what is the mandate that have been given? If you tell them that they can actually manage, first aid is fine, it's just the normal ABC, the normal ways, but you must look at it clearly that will there be will there need to have a prescription, a well-prescribed way to have these hub and spokes operationalized when the community is working, because otherwise we'll have a lot of deaths that will be occurring within the community, because yes, the community promoter has identified a case, has actually seen somebody who for a long time has not seen the need of going to the hospital, rather being go to the hospital or to the facilities, but they get more frustrations by going to that place. For example, and I said this earlier, if somebody has been given BP machines, the way they say they be given all this, and they've been trained how to actually check the BPs, you go to a person in the village and tell them, oh, now you have hypertension. So what? Mm-hmm. Yes. Mm-hmm.
So what next?
Because, yeah, what next? Because you know very well that this person has to be managed for this. Otherwise, these particular situations will actually exacerbate stress among these persons.
So as we're having this conversation of employing was it 100,000?
Yes.
Commissioning, actually, let's not say employ. Commissioning 100,000 community health promoters. Are we having a conversation about employing healthcare workers?
And that's where we were saying that ideally...
Is there something, yeah.
Ideally, it will have been much clearer when this plan of community, of a primary bill or primary healthcare bill comes into context with ensuring that, fine, we have the 100,000 community health promoters being put into role or into action. And actually, they need to be they need to be given better incentives. That's one thing. Then number two, we need to look into that perspective that the 20,000 healthcare workers that were promised, are they going to go hand in hand with these community health promoters that are being employed? Are we going to ensure that these particular facilities, level 3 and level 2 that we call the spokes functional? Are we going to ensure that this hub, the level 4 that is within the county, is functional? Otherwise, if that is not looked into, then there's nothing we're doing. Because many countries, 40 years, have experienced these challenges. And we are fronting ourselves to the same challenges if we don't invest, if we just become rhetoric. The other thing that I know from that bill, it has brought about the institutional framework of management of the community health promoters or services, because it has the national concept of it. We have the county coordinating part. We have with the committees down. So we kept on asking ourselves that when it comes to this community health or primary health care thing, there's a very strong interest from the Ministry of Health. There's a very strong interest from the county government. There's a strong interest from everybody. Is it donor-driven? Or is it just an honest the interest into this process to work? Why am I saying this? Because we have made noise about the shortage of health workforce across the country. We have really spoken and have discussions and tried to advocate on the need to have every Kenyan access to care in these particular hospitals. But then we're being told health is devolved. That's the conversation that comes every day. But we know very well, as much as it's a talk that health is devolved, being a Kenyan has never been devolved.
Why is it so hard? Because it's very unfortunate we are talking about this 20,000 promise, that it is still a promise even today. How come it's still a promise? Why is it so hard to just increase the population of healthcare workers in this country? What are the complexities? Probably let's open this conversation up a bit.
Very good one. I think I need actually to appreciate that you are doing this to sensitize the community that it is their right. Under the Constitution, it is their right to demand that our leaders do the right thing. And it is not doing a favor if we employ healthcare workers to ensure that everyone can be able to access the services they need and they're available to the community. Let me start from where you started by asking, who will determine what is a mild infection or the diseases that can be treated by these people? I think that's a conundrum, and we have raised, that's one of the issues we have raised on that bill, that this definition here attached that the community health promoters can do this. We are now a regulated country. Professionals are regulated. In terms of what I can do, to what extent it's already provided. So to this extent, mild illnesses that can be treated by these people is not defined. And of course, I know that they're already architecturing, trying to think on what they should be able to do about that. And what is that is a mild, can mild infection kill? If it can kill, is this supposed to be? So we need to look at that. What are the injuries? Do they have that capacity to determine this is a mild infection, this is an injury that I can address? Is it wound care? What is it? So those are issues that still are there, and I know that when we raise them, the ministry have been thinking about it, and they have been in Mombasa the course of this week, still trying to put things together. Now, what he talked about when they are moving around with the BP machine, one thing that we appreciate is about the 4 bills. Both of them speak to each other. There is now what we call the digital bill. The digital bill will interlink because they will be having a gadget. So if today you are moving around as a community promoter and you meet Gibore, and by virtue of doing, because now it is an integrated services, if I meet, because they will be instructed that anyone who is at 35 years and above, please ensure that you are able to, because we want to identify those cases early enough, because a majority of us are living with probably chronic illnesses without our knowledge. So So for us to ensure that these people are breaching the gap where these people could not access the services by virtue of the distance between where they live and where the facility is, and they see no need, because either they have to choose whether to go and graze their cows or to go to the hospital where they can buy some paracetamol because of the headache they have, and they continue with their life. So these people, when they do that, they will keep these details in their gadget. There should be a facility, because this community promoter will be attached to a certain facility. So there will be someone to follow up. So once you key in, I'll be able to do that analysis, assess, and then call and say, no, you were in so-and-so, you have seen so-and-so, I think this is an alarm, bring this person, or we send an ambulance to pick this person. I think that is when now we say it can function. Now that one will be now giving meaning and sensible services that we are talking about, the bridge that these people need to bring. Why I say that is that these 4 bills are speaking to each other because they need really to support each other to ensure that the primary care services is functioning. Now, to what you talked about, why is it that it's difficult for us to employ? And why I had to speak about what the CS, I have seen the CS talking about without focusing on the healthcare workers, is because the Kenya Kwanza, because they say they are implementing what Kenya Kwanza promised. One of the things they promised is to employ healthcare workers. There is no budget. So you cannot say that there is a right projection in terms of how we need to move forward to populate, or rather to increase the number of healthcare workers in the right mix of skills that we need in the health system for us to function. There is no focus. As to this time, we do not know any discussion that is going in. And one thing that whenever we have interrogated this issue is that the ministry is trying to shy away, because every time they say we need to do this, the county comes God's blessing. Because I know when the president was speaking about this issue, they come out and said, you're clawing back the issues of health. And this is where now we come as professionals and say, I think it has come a time where we need to do an health audit. We do an audit in terms of what is missing in this disintegrated management of the health system, where you have counties want to do this way, so that's, and the national government want to do this, and then whenever there is a fight, then it is left for the Kenyan to continue suffering. So the right thinking is that we really need to establish a central system to manage especially the human aspect, the human resource aspect in the health system, so that we have a one thinking, a one approach. And we normally ask, if today we have like whichever they don't want to hear about the Health Service Commission, today employing healthcare workers, sending them to the county, promoting them, paying them in time, because paying in time is a key issue where the majority of healthcare workers have been going on strike because they don't get. And also ensuring that they can release them as need basis to go for further training. They can also ensure that these people are able to move from county to county through transfers. Yeah. Will that really be clawing back the gain at the county? It's no. Will be actually supporting the county. But they do not want to see this because they are doing business with the money, and even when the money is given to pay the workers, they delay for 3 months doing business with it.
Yeah, I want just before we continue, I want to understand the difference between that proposal to have a Health Service Commission and what the mandate of the Kenya Health Human Resource Advisory ought to be. What's the nexus or lack of it?
You know, Safin, one thing that I must credit this government for, I mean, it must be honest also, is that I think the executive, the president, had his really interest in ensuring that there is human resource aspect of healthcare, and I will call it health workforce, is well managed. And that's why you realize that the health bill of 2007 had this care track, which was to manage the human resource between the counties and the national. But for all these 6 years, it was not operationalized. So we must actually give credit to the Ministry of Health, even to the CUG and to the national, to actually have this care track operationalized. But
so is it going to address the issues that you had hoped the Health Service Commission?
That's a question, another question. Because you see, this particular care track is it does not have an enforceable mechanisms into the issues that are affecting health workforce. It doesn't have the finance that can employ. It doesn't have the finance that can actually ensure that we have a particular number of doctors, health, nurses, clinical officers, technologists in every facility as expected. But the fact that it was institutionalized is a clear indication appreciation that there's a problem. They must, like they have accepted there's a problem here. So that's the first thing. But then let's look at it, that what is making healthcare actually not to function in the country? The biggest issue is the budget. We know very well that for health to function, there has to be funds that follows it. We have, it's being said that health, it's actually a reality that health is devolved into the 47 counties. But in the last 6 years, there's been no employment of nurses, there's been no employment of doctors, there's been no employment of any of this health workforce. In fact, the employment has gone to about, has reduced to the extent of about 10% of those who actually graduate every year get employed. And the population keep increasing, the disease patterns keep changing. But what happens in those facilities, it means that every person who visits the hospital, the public hospitals, they have to be frustrated. That's why we have a lot of thronging in the Moi Teaching and Referral Hospital because of the service they offer. We have a lot of thronging in the Kenyatta in KUTRH and in KNH. And that's the reality that happens there. And the government is coming with policies to ensure that those hospitals, national hospitals, are decongested. So many Kenyans will actually end up going out-of-pocket expenditure in the private facilities because the government has not invested in healthcare.
So as we try to decongest this main hospitals, even through initiatives such as rolling out the primary healthcare to ensure that at least those diseases that can be treated at the lowest level can do that, you're saying the lack of good services at the lowest level and the lack of the healthcare workers who are supposed to be, handling these cases at the local level would still kind of be would still lead to the same problem that you're trying to solve.
It's actually there. It's actually leading to it. That's why you realize that, for example, we saw that a very serious case last time that was sensationalized, that was in the media, on this boy, it's a sad thing, of Kiambu, Master Travis. Ideally, this issue should have been handled in Thika level 5, because that's the level 5. It had not to reach Kenyatta. We also have cases whereby mothers are losing their lives in Mama Lucy. And why was that happening? Because there's one nurse who is attending to another patient and is expected to attend to another one. That shortage is reality, and that's why people are still suffering. This is just an epitome or just a tip of iceberg for issues within the counties. In the counties, you will go there for a clinic and be given to come after 3 months. You will have surgery procedures and the reason why that's happening is because of the health workforce. If you look at the budget that is currently for healthcare in the country, we have 18.3 billion of it in the universal healthcare.
Is it at least 15%?
6.6%. It's still low. But the particular one I'm interested in is the fund for universal healthcare. It's 18.3 billion. Out of that, 5.9 billion is for management equipment services, MES. We know that these are the budget in last year and the previous year. The report indicates that the MES project was not functional in many places, though it was a very good concept. Why? Because it was bringing equipment and diagnostic abilities to different counties across the country. It did not function because there was no health workforce. There were no doctors, there were no radiologists, there was nobody who could actually make this equipment function. But we are seeing still part of the budget without the budget of the human resource part of it to actually make them function.
And I'm still here asking, why are our hospitals empty? Yet we train every year. People graduate the different cadres of the health sector every year. And I also like to interest you in an example outside. I was following a conversation, Dr. Victor Ngani, the founding chair of the Doctors Union. Yep. He was saying that, he cited that Kenya is training doctors each and every year, but like in 1999, we had 3,000 doctors. In the next 10 years, past 1999, we trained more doctors, adding up to about 1,200. But in 2011, Kenya had only 2,300 doctors. So that means we went back below 3,000. And even these ones that we had trained within the 10 years after 1999, we still lost them. These ones go abroad to look for jobs. This is just an example. I'm asking myself, what are the factors? Why is it that we don't have these people that we train work in our hospitals locally here in the country? What is the situation? What are the factors that would lead,
for example...
Both of you can just weigh in.
Yes.
Maybe before he come in, let me wait to the first issue that you had asked about the KHHRAC, that's the Kenya Health Human Resource Advisory Council. It is a concept that we were pushing then when the Health Act was coming, because our thinking then was we were looking at how governors were under what we call the Health Service Commission. Then we said, can we architect something that we can maybe improve on in the near future? The way it is, I can assure you that it might not do anything, because one, it cannot transfer a healthcare worker, it cannot employ, it cannot even call someone and apportion that you have time to go to school.
So
it cannot do anything.
So what is it exactly?
What happened is that if you look at the Kenya Kwanza promises, one of it was to establish actually the Health Service Commission, which in consultation with the county to manage the human resource aspect. And the thinking there, which was coined, is that about what I was saying, that if you give a right body to manage the healthcare workers, to support the county, to avoid this back and forth thing, then will you be supporting the county or crowing back? So that is the discussion that can be there. But the way it is, why the president had to do that was because he was told that there is already a body here which can be able. But the way it is convoluted. Yeah. Like when they say they will keep the register for all the healthcare workers, that is a function also under what we call KHPOA. It is also a function under the respective regulatory body. So it's a body that probably will never take off. And it's better that the president be realistic. If he wanted to achieve something, he better know that that's a body that might not assist him to achieve whichever he intended to do. Because he has I think every goodwill that he feels that he needs to support the health to function properly. So that is something that probably might not assist him, because they can never be given budget to employ. They cannot do anything. You know, they are just there. They can't even negotiate a CBA.
Because I thought actually it could fix.
They can't negotiate a CBA because one, that is that is still at the employers.
The reason why I really differ a little bit with my brother here is that we've had a back and forth with the national government and the county government and all different bodies discussing this issue of healthcare. So as much as this body do not have enforcement matrix over the issues, I still tend to believe that it's a step in the right direction. Why? Because then now it has members from the Public Service Commission, it has members from the Council of Governors, it has members from the Ministry of Health, and it has members from the training institutions. So as much as it is, it's able to actually concretize this information, these issues that we have, with inputs from the unions, from the ministry, from all that, and then now communicate one language that this is the problem that is existing.
So the communication aspect has been solved.
That aspect of criticizing, of making this issue to be one, so that even the president says, okay, fine, if this is a healthcare problem, he doesn't only listen to the Council of Governors, he doesn't only listen to the Ministry of Health, but this acts as a neutral habitat over these matters. I think that's where I find that its action will actually be beneficial. But rather than,
do you also feel like it's limited in terms of...
It is extremely limited. It's extremely limited, and we know very well that laws can be amended. Once, if there is a goodwill with the executive, is the goodwill with the counties, and there's actually goodwill to actually implement healthcare as we need, then laws can be amended. The provisions that we need to actually make the KHRAC work to almost a synonymous way with the Health Service Commission or any of these bodies will be easier when everybody, the parliamentarians, and everybody says, oh no, the issues that are actually there can be done. Okay, so that's something I look at. That's
very positive. But my positive about the HRAC is that at least someone is realizing we need a coordinating body.
Yes.
That is one thing that I only realize. But whether it will function, I'm trying to say that we should not put hope where it might not take off.
So you see,
we must be realistic that we have this body there, yes, but it might not do anything because it cannot recommend. You know, when we went to county realized we cannot do much. That is why they proposed the establishment of the COG. The Council of Governors. That Council of Governors is there to coordinate the activities of the counties and be the voice of the counties, individual counties. But when the healthcare workers are proposing such a things, they are looking ridiculous. And I do not understand why, because this is about service. If anyone was to look at the pros and cons about it, is that actually we'll have more benefit than actually the way we are thinking about politics, because everyone is about politics. That now counties are looking like I will not have that priority. When I am there, I employ my own people on contract. Then I'm not there, I chase them, I bring others. That is business that will never actually promote the health services, or rather strengthen the system. So for me, my call is that President must be realistic, that he has a good idea. And it's good that, of course, he's looking like we need that central body to do something. But what is it that what we have currently, the center is not holding? So it must probably we work on what he's saying, that we amend the law where necessary and ensure that we have what we want to take us to point B where we want.
The reason why I'm saying that, Safin, is because we have been talking about Health Service Commission for 10 years.
Yes.
We have had the different governments, and even this particular KHDAC was not operationalized. So I think it's a step in towards that, because everybody can actually see. If he doesn't really do the job, we will just say this is nonsense, reality. But I mean, it's good to actually see to it that the functions that have been put there, like welfare and schemes of service for health workers, we actually need to put it into account. And also, there should be a way that the counties actually obey the commands from these bodies that are constitutional bodies, or bodies that have been put in place, or the bodies that have been put by Act of Parliament. There's something you asked earlier, that why do healthcare workers, despite the graduations that they have every year.
Just doctors.
Doctors every year, healthcare workers every year, we still have a big shortage.
Nobody wants to work in Kenya.
I want to give you a particular example of the doctors. We have 13 universities currently about graduating doctors across the country. And the number of doctors that we come into country, for example, that graduate every year, if I talk about the medical practitioners, the pharmacists, and the dentists, it's total about 950 to 1,000 every year. We look at how much, what numbers do the country employ annually? You realize it is about less than 10% of this. For example, in 2022, 2023, 2024, 2022, 2023, we have only about 40 doctors that have been employed out of the 950 that are graduated. It means there's an injection of unemployed about 900. So it is essential that everybody who graduates, they actually look at it that, I mean, I have to survive. But while this is happening, what is the shortage in the country? And many people are saying we should get away from looking at WHO indicators for health workforce, while the same UN recommendation is what is used in the police, because that's why the Kenya is employing police every year. The same one they're using in the armed forces, the same one they're using in employing teachers every day. But they're saying in terms of health, let's not look at that. Let's look at realities, the service versus the numbers. And I will tell you, the whole country, we have about 5,000 employed doctors versus 56 million population. It means that the service delivery is actually hampered from the beginning. From the COG itself, it indicates that it needs about 50,000 doctors to actually have efficient service delivery, to actually have those hubs and spokes to be functional units, even in the primary healthcare, even in now the curative and all these approaches of healthcare. But there's no deliberate investment to have this employment. So we have, we call it an artificial shortage, excess that has been created, while there's big shortage within the facilities. And I keep on saying, the reason why this is happening is because the governments have not put their priorities to the people. Why is it so? Because all these political leaders, none of them actually visit the public hospitals to get care in that. And even if you look at the NHIF, the way it used to be, about 70% of it used to go to the private hospitals. But now the social health insurance that is being created actually makes even all the government bodies and all the employees will all be moved to private insurance. Because even that component of NHIF that was insuring the civil servants, that was insuring the different bodies is being removed. Why? There's a competing interest with the private insurances on this. And that's why we keep on looking at it, that some of these bills, they may look good on the surface, but at the end of the day, there's a behind private profit that is steering its
Let me mention about whenever they say that numbers doesn't lie. Yes, that numbers doesn't lie. It's very true, because the numbers portray the government like a government that probably priority is not right in terms of health. Because we are talking about, like clinical officer, we have now 27. By the end of this year,
27,000?
27,000. By the end of this year, we are clocking around 30,000 clinical officers. Now, how many are employed? We have around 8,000 employed in the government. In the year 2013, we were only producing around 900 clinical officers. Now we are producing around between 3,500 to 3,900. That number is huge. But is it huge that we are above what we need? No, because we need around one clinical officer to 500 people. If at all, we have to have a system working. So that is a clarion call to the government that we must awake and put our priority right, allocate the resources to health that can be able to function. And it's good that we are thinking the right way so that we are reserving, including the money that we want in health so that it can function.
All right.
And employment must be harmonized. And it must be focused, and it must be specific. That this is what we want to achieve, let's move there. Let's leave these cosmetic things and politics in the health sector.
All right, as we wind this up, this is like the fourth attempt to really making UHC work. How do we get it right this time, as your closing remark, Davji?
I keep on saying that UHC in this country is a pipe dream. It will not work unless we actually have a deliberate prospect to invest in healthcare. And it is not a matter of just lip service and saying that we UHC, because it has failed in those previous instances. Number one, there has to be a proper investment. We must actually finance healthcare. And it has to be seen within the budgets of healthcare, both in the national, even in the county governments. Currently, as a country, we have a budget of 5%. And that's why all the county hospitals are not functional. So if we improve these budgets of healthcare to 15%, there'll be hope to see universal healthcare. There's another thing that we have to look at. We have to look at the commodities. There was to restructure in KEMSA to see the drugs in the facilities. Are they there? The last thing, which is very key that has been forgotten, is the health workforce. There has to be a plan for annual employment of health workforce in the country. And lastly, we see strikes. For example, now we give notice as doctors in Embu, in Nakuru, in Kakamega, in Busia. Why is this happening? Because of the frustration. There's a swelling disillusionment of health workers within those particular counties. So there has to be a way to motivate them and make them actually be retained, not to leave the country for greener pastures.
Thank you so much. Dr. Davji Atela, the Secretary General, Kenya Medical Practitioners and Dentists Union. I was also engaging this morning George Gibore, the SecGen, Kenya Union of Clinical Officers, as we were talking about the state of healthcare this morning, delving into the practicality of successfully implementing the primary healthcare as it has been proposed by the government. Of course, the bill still needs to be tabled in Parliament, and then it will go through the entire process of the first reading, the second reading, before it becomes actually law once it is assented to by the President. But that conversation continues just to enlighten you on what these bills promise for you as a Kenyan. My name is Afina Ching. Oma, thank you so much for creating time for us for Daybreak this morning. But keep watching Citizen TV. There is a lot that we still have lined up for you. But for now, it's a wrap. Have a lovely day ahead.